Today we are going to answer frequently asked questions about embryology, and we received a lot of questions to our email. So firstly, we will answer them, and after that, we will answer questions from the chat. Just to remind you that you can ask all the questions in the our chat, and we will answer them after our presentation. So I'd like to introduce our speakers, our embryologist. Our first speaker is Birol Aydin, a director of IVMED IVF laboratory. He's a senior embryologist and official expert of Society for Human Reproduction and Embryology. And our second speaker is Olha Chaplia, PhD, senior embryologist at IVMED Embryology Laboratory, ESHRE certified senior embryologist, also from Medical Center IVMED. So we will start with questions. And just a reminder that we have an active chat, and if you have questions, you can ask them. So our first question is, hello, could you please explain what is embryo glue? Do you have this technique in your clinic? For which type of patients do you use it? Please, Birol, welcome.
Hello everyone. So embryo glue is the special media which is actually helping during the embryo transfer for the implantation potential of the embryo. So embryo glue has special composition inside, which is increasing in same time capacity of embryo for the developing, and also it's helping like cross-matching of endometrial receptivity and embryonic development. Of course, this is media-based technique, so it's not special like mechanical technique or some other technological explanation here. Only we are using based of media, which we get exactly pH inside of endometrium, and to try to help much more energy for the embryo for the development stage, especially for the implantation process. Media composition prepared by the Vitrolife company, and of course, as IVMED also we are able to use such media, depends of interest of the patient. There are different kind of research and publishment about embryo glue. If you look this publishment, so we may see, especially for the recurrent like IVF attempt, like which has many unsuccessful implantation failure. So with embryo glue, that's almost 10% of case which has implantation failure get a positive result. Of course, 10% when we look like from each 100 patient, 100 embryo transfer, 10 transfer back a positive is a good number. And of course, we can suggest to our patient to use embryo glue technique with the transfer. And we are able, as IVMED Clinic Embryology Laboratory, to support with embryo glue.
Okay, thank you for your answer. So our next question, do you have a cryobank in the clinic? I want to try IVF with donor sperm. Can I choose, for example, a donor with blue eyes, etc.? Please, Olha.
Yes, of course, we have a cryobank in our clinic. It is quite a big one, and we store their embryos, eggs, and of course sperm, including donor one. And we have a quite huge list of sperm donors, so you can select the one that you really like, including the blood type and also the phenotypic characteristics like stature, height, eyes color, hair color, and we even have the specimen of their handwriting and their child photos. So no problem, welcome. Thank you.
Okay. Thank you for your answer. Our next question is quite big. I am 40 years old. My AMH is 2.1. I tried IVF several times. Last time after retrieval, I had 10 eggs, but only 3 fertilized, and they stopped the development at the day 3. Previous attempt also embryos stopped development at day 3. What can I do to prevent this, or just use donor eggs? Please, Birol.
Okay. While when we looked at anti-Mullerian hormone, 2.1 is not bad. So that's why she got a 10 matrix, mostly above the 1.5 AMH. So we are able to get quite high quality of oocyte with the maturity, but because of the age, of course, especially calcium activation inside of oocyte and like a plasma permeability is much more low because like age is increasing. Of course, that affect directly to fertilization. In this case, like mostly embryos stop on the 3rd day, and only like 30% of oocyte get fertilized, as we see the case. There are, of course, different factors affected. Firstly, we are not able to talk about genetic potential of the oocyte and sperm differently, and plus also embryos. This can be one of the factors. So some kind of genetic translocation or anomaly can create a situation. Second, of course, laboratory condition, culture media condition, it can affect the situation. And of course, like for such case, always is better to use time-lapse technology because we will be more able to understand like exactly reason of stop developing and which stage we get this undeveloped embryo. So what we can do for this case and what we can suggest, of course, to use donor eggs as an easy solution, but mostly all patients try to get first from their own eggs. Basically, when we try to get oocyte after the oocyte pickup and denudation, we are trying to get like timing much more proper than normal one. Okay, we are waiting normally after the oocyte pickup like 1-2 hours to get for the cumulus complex to clean as denudation we are calling, and then we are waiting 30 minutes to 1 hour for the ICSI, like intracytoplasmic sperm injection. Of course, in this case, we can get shorter this balance to give much more possibility for the energy activation, and we can use artificial calcium treatment to give more potential to oocyte development. Of course, like we have to analyze well history of the case, so like which culture media used, what kind of technique they made fertilization. According to that, we can get a different kind of strategy. As IVMED laboratory, we are working with multimedia technology, so we can use a different media for the different case. And I believe if we add also time-lapse technology, so we can get a better result, or at least we can understand the real situation. But of course, like first proposition before the start cycle, for sure to get karyotype result. So we will be able to see if there is any translocation for male factor and female factor, both as well. And after that, finally, like all station will be happening in the laboratory. So we will use additional techniques and technology to try to change station.
Thank you for your detailed answer. And our next question, I want to have twins. How many embryos can I transfer to increase chances? 3, is it possible? Please, Olga.
Of course, in this situation, we are also limited by Ukrainian legislation. According to it, we can transfer 3 embryos only in difficult cases. It means that you already encountered a couple of IVF treatments without any results. You have poor embryos quality. And of course, in such situation, it is allowed to transfer 3 embryos. But In all the others um, conditions, we insist on transferring only one embryo or two. So if you really like to get twins, it is better to transfer two embryos of high quality, grade AA, or even better to go for NGS testing and be sure that these embryos are euploid. It means they are healthy. And of course, being healthy, they have higher chances for implantations, for implantation. But from the other side, please keep in mind that twins is not only very cute photos, it is also the risk of maternal and antenatal complications. So there's a reason why we usually have single pregnancies. Anyway, good luck.
Okay. Thank you.
Just I want to add one
sure.
thing here, if it is possible.
Yeah, sure.
So finally, there are a lot of research and publication which shows there is potentially no difference between single embryo, double embryo, or triple embryo transfer. Why? Because it's aneuploidy and abnormality rate is much higher than other age group. So that's why we suggest for all patients above 35 years old to use PGD or NGS technology. Of course, as my recommendation, personal recommendation, if they have any kind of especially implantation failure before, or if they have abortion risk or such kind of situation in their story, or they are closer family, of course, best situation to try NGS technology and to get information from all chromosomes. But if they are using that only purpose of to know, for example, sex gender, or to know like a main chromosomal aneuploidies or anomalies, which is responsible from the abortion, from trisomy, and then PGD5 or PGD9 chromosome will be totally enough. But again, as my personal perspective, I always prefer NGS technology because it's giving much more information to us.
Okay. Thank you. Our next, we have actually two questions to Olga. First one, hello, after PGT, I have one mosaic embryo. Can I transfer it? And the second one, I have 4 BC, 3 CC, and 3 BB embryos. Can I transfer 3 CC and 3 BB embryos together? Please, Olga.
Yes, according to regulations of Society of Preimplantation Genetic Testing, you are able to go on for embryo transfer, even if it's proven to be mosaic according to PGT results. But in order to give a really strict recommendation, we lack information about the type of mosaicism and the chromosome involved. Because actually, the chance for this pregnancy to implant and what we fear most, to give a pathologic pregnancy, really depends on these important issues. So firstly, we need to know whether this embryo is high mosaic. It means that it has more than 50% of abnormal cells. And what chromosomes are involved in this pathology, because different pathologies may lead to different outcomes. Overall, mosaic embryos have lower chance to implant compared to euploid one, but still it is proven that mosaic embryos also can give normal, healthy pregnancy, because mosaicism may be the artifact of a very sensitive testing technique. So in order to get a really right answer, it is always better to go on for a consultation with an IVF specialist and to show the result of testing of this embryo and its quality, of course. And the second part of the question, well, obviously you have a chance to transfer 3cc and 3bb embryos together. Of course, you need to remember that embryo of cc grade has is of let's be honest, poor quality, and it has very low chances to implant, but it won't influence the other one. If 3BB is ready for the implantation and endometrium is receptive, then we can hope for a healthy pregnancy anyway. Moreover, today embryologists do not have one unambiguous answer to the question how embryos interact, whether bad embryos may influence good ones. But as we know, today embryos can interact, but still they do not interact so strictly. They are not able to develop independently in a uterus, and you may see the improvement of it by very numerous twin pregnancies that occurred after IVF treatment. So, of course, go on. If your IVF specialist recommends you to go for such transfer, and you have such an option, and you are sure that it is right, then it is okay to use these embryos for transfer. Thank you.
Thank you for your answer. Just to remind our guests that, as Olga said, that you can have an online consultation, and you can see in an email our contact email, and you can send us an email if you want to have a consultation with our embryologist or fertility doctor. We also have other specialists, so you don't need to, for example, visit Ukraine. You just can be at home and get your answers and have your personal online consultation. Feel free. So our next questions, also about embryos. I have 5 embryos, all 6-day, quality 5AA, 5BB. Is 6-day blastocyst good for embryo transfer? Please, Birol.
Okay, actually, for the quality of embryo, if you look, 5A embryos between 5-day and 6-day, there is no potential difference as morphological. But what can be effect to transfer? There are 2 different kind of option here. And first one, researchers are saying, okay, if you have embryo on the 5-day stage, that you can go ahead to make a 5-day embryo transfer as fresh. But if you have a 6-day embryos, because of the implantation window of cross-matching, or you have a chance to miss the implantation window. So they say, okay, if you have a 6-day embryos, blastocyst, better to freeze and to make next cycle embryo transfer to give more chance for implantation window. But of course, there are several different research which a group of clinics use 6-day blastocyst for the fresh embryo transfer, and they got good result, but such research are limited. Our experience also, as we are working 95% of frozen embryo transfer cycle, that for us, between 5-day embryos and 6-day embryos, if they are healthy genetically, if we have chance to make NGS testing to them, and if they are healthy, there is no morphological difference. So this is only kind of metabolic activities inside of embryo. So some of them developing more faster, some of them more slower. Also, there are different kind of mechanic effect is possible here while we are doing hatching for the biopsy, embryo biopsy. Okay, sometimes it's possible zona permeability is more low, so embryo getting hatched more faster. Sometimes it's not possible. They're developing and hatching like 1 day later. But basically, there is no difference between 6-day and 5-day good quality of blastocyst.
Thank you for your answer. And also the next question is also for you. I am 35 years old. I had 2 miscarriages and 2 biochemical pregnancies. Planning to do IVF, should I do PGD?
Okay, as I say, above 35, always there is risk, and we have to talk about embryo aneuploid rate. So as I say, 2 miscarriage and 2 biochemical pregnancies, so it's symptoms of, it shows there's some aneuploidy or anomaly on the embryos. Of course, there definitely should be pre-implantation genetic diagnosis, and while we have history of two miscarriage and biochemical pregnancy, so totally suggest to make NGS total chromosome testing.
Okay, thank you. Our next question, is it safe to defrost embryos for biopsy? Please, Olga.
If the embryos are of high quality, and if they were frozen appropriately, I mean, the appropriate media were used. It is vitrification process, because we still remember that in some laboratories, in some countries, slow freezing is still in practice. Then you don't have to worry, probably. If experienced embryologists, like the ones that are working in our lab, will work with your embryos, they will survive the sewing process, and of course they will survive the subsequent biopsy process, and of course they will survive the subsequent frozen process, because actually healthy and high quality embryos have a very high survival rate after modern vitrification and sewing technique usage. So it is not only safe, but in some situations it is useful to go on for such a technique if you're opting for NGS and you already have frozen embryos. Don't worry, everything will be fine with them. Thank you.
Thank you for your answer. The next question is, do you perform pronuclear transfer at your clinic? Please, Birol.
We have possibility of pronuclear transfer in our clinic. So let me try to explain a little bit why we are doing pronuclear transfer. Pronuclear transfer mostly when we have totally low ovarian reserve. So they have almost 1 or 2 egg, but of course, because of the age factor or for polycystic ovary syndrome or different metabolic factors, oocyte quality is really low. So that means cytoplasmic activity is low, and there is possible mitochondrial DNA disease occur during the embryo developing. So for such case, of course, there is an option to use their own genetic material to carry up during the pregnancy. So basically, we have patient oocyte, we have her husband's sperm, their own material, and from another side, donor oocyte. So we fertilize both with husband's sperm, and both already are fertilized from the same genetic material. So what is our aim here? To use a cytoplasmic activity and high quality of mitochondrial DNA of the donor eggs, and to use like genetic material of intended parents. So what we are doing, we are just getting the pronucleus from the patient oocyte and to transfer to inside of donor oocyte. In such case, we are giving two possibilities. First, to release totally mitochondrial DNA disease, and second, to give chance to cytoplasmic activity, because of cytoplasmic activity, to more potential of the developing to embryos. So according to our experience, of course, we are choosing carefully case of the patient for pronuclear transfer. Of course, there are different kind of limitation for that, but our experience already shows a good result, because mostly pronuclear transfer done as last choice. So because there is only the technique what we can use if we don't use pronuclear transfer, only egg donation. So while according to our experience, from each 10 transfer, 4 of them is giving clinical pregnancy for the pronuclear transfer. And we have to know those cases only have 1 or 2 eggs. So there is almost low chance to get from the natural concept or IVF concept to pregnancy, but still pronuclear transfer is giving them a chance to get their own genetic material. And they have to know only 1% of the donor genetic, like a donor gene will be carried up as mitochondrial DNA, taking only 1% of total DNA. So mostly they will carry up 99% of their own genetic material.
Okay, thank you. Our next question, what is an accuracy of NGS? Is it possible that the baby will have some abnormalities after all? Please, Olga.
Nowadays, new generation sequencing is considered to be the most accurate technique for embryo testing. It is evaluated to be 99.9% accurate, but still we should remember that it is testing for so-called chromosomal abnormalities. It means that it will show the pathologies of genetic material of a quite big size. You are not able to test for so-called gene diseases like cystic fibrosis or spinal muscular atrophy. With this technique, it is a separate testing that also can be done together with NGS. So you can test embryos for definite gene disease and also for chromosomal abnormalities with NGS testing, but NGS testing by itself won't give you the full information about all the gene diseases that embryo has, only about chromosomal ones. And of course, sometimes, quite rarely, false positive and false negative results may occur, and it also should be taken into account, but it's a very rare situations. So in the most cases, we can be sure that embryo that will be transferred to the uterus after NGS testing will be healthy and will have higher chance to implant and to give a normal pregnancy. That's why we are using NGS testing in order to avoid pathologic pregnancy occurrence, to decrease the chances of spontaneous abortions, and of course to assure the future health of the child.
Thank you for your answer. I had some problems with my presentation, but actually that there was the last question from our presentation. So I just need to check our chat quickly. Just to remind to our visitors of our webinar, we have a chat. You can ask questions if you want to our embryologist. So we have questions. Hi, what percentage of healthy embryos can I have if I am 40 years old? Please, Birol.
Okay, like generally statistics shows and publication shows after 40 years old, like almost like 40% of the embryos, general embryos, has aeuploid number after the NGS testing. But of course, there are a lot of different factors which is affect number of embryos, of course, because 40 years old, like ovarian reserve is not so big, so number of oocyte will be limited. Of course, we have to talk about number of the embryos. If we have 10 embryos, like for that age, we can say we are waiting actually 4 to 5 embryos will be aeuploid at least. Depends of course, also male factor. But if we have less number, of course, chance is much more low. Mainly, like, as I say, 40 to 50% of embryos at that age depends of, again, I'm saying male factor. And if they don't have any genetic factor, which is coming from their family history, so we are able to get in good IVF laboratory with good condition, like 40 to 50% of blastocysts aeuploid.
Okay, thank you. We have a next question. Just to remind you, if you send the question and you don't see it in the chat, please just send the question again. It seems some technical problem that we don't receive some questions. So next question. Hello, I'm 39. I have freezed eggs at age 35. What is better to use, my fresh eggs now or eggs that I froze before? Please, Olga.
Talking about the perspective, of course, it is better to use oocytes from that were frozen because, as we already mentioned, advanced maternal age is a factor of unemployability risk. But from the other point of view, if your follicular reserve is quite good, you can go on for OPU today and to have these frozen frozen oocytes stored in case you need them. And if the results of OPU won't be so promising as we want them to be. And as a third option, actually, you can combine these two variants and you can go for OPU in order to see what we actually will get in a fresh cycle. And at the same time, so oocytes that were frozen when you were 35, and to increase the general number of embryos that, of course, may increase the chances for getting high quality blastocysts and getting pregnant in this particular cycle. So better, in order to select the best decision, talk to your gynecologist and take into account your current state of health. Thank you.
Thank you for your answer. We have another question. Is pronuclear transfer the same as third-party IVF? Please, Birol.
Yeah, actually, different kind of terms we are using for pronuclear transfer. So there are two kind of way to get a pregnancy or to get a child from this way. One is pronuclear transfer, another is spindle transfer. So both we are, and also cytoplasmic transfer, while we are calling all of them as a third party of IVF. So three of them are possible to give chance of pregnancy. So in IVMED, at the moment we can give service of pronuclear. Also very soon we can give service of spindle transfer. So actually cytoplasmic transfer is coming much more back because quality of the embryos after the cytoplasmic transfer, which we didn't achieve how we wait pronuclear transfer and spindle transfer. So maternal spindle transfer and pronuclear transfer are much more effective. Let's say, what is the difference? Of course, pronuclear transfer is giving much more promising because almost all oocyte is fertilized. In maternal spindle transfer, so oocyte still not fertilized. So after they remove the spindle and exchange with donor spindle, so still we should wait for the fertilization. Still, there is a risk of fertilization failure. But for pronuclear transfer, so oocyte already fertilized, we are just exchanging pronuclear division. So after the next day, embryo already start to get a cleavage mode. So second day, third day until blastocyst, if there is a potential, like on the embryos, so it's developing till blastocyst stage.
Okay, thank you for your answer. The next question, what day should we freeze the embryo to be sent to your clinic? My clinic wants to freeze them at day 1. Please, Olga.
Well, let's be honest, it depends on what you plan to do with your embryos. If you plan to go for a surrogacy program, of course, it would be better to culture embryos till day 5 to be sure that they will form blastocysts and you will have a high chance for pregnancy after this embryos transfer in a surrogate uterus. Because of course, embryo shipment to other country, it takes a lot of effort, a lot of time, and a lot of money, of course. And I don't think that frozen embryos on day 1 is a good option for such a plan. But from the other point of view, if you want to go for NGS testing or PGD for 5 or 9 chromosomes, as an embryologist, I would recommend you to freeze embryos on day 3. and to send them here for subsequent sewing and culture, because sometimes due to some technical issues, it is a little difficult to work with blastocysts that were frozen in a different laboratory and sent for subsequent defrosting and biopsy. So if you already know that you want to do PGT, it is better to freeze on day 3 and send here for subsequent sewing. But of course, please give us a little bit more details about your chances, because it also strictly depends on the number of embryos. Because if you talk about 2 zygotes, it's one situation. And if you talk about 22 zygotes, well, we have different options in such situation. So please give us a little bit more detail. Maybe you need more individual answer, or maybe what I've already said is quite okay for your case. Thank you.
Thank you for your answer. And the next question, if I am post-menopausal, is there any way you can extract eggs? Please, Birol.
Okay, like on post-menopause case, of course, it's extremely difficult to get this answer. Okay, this question a little bit about, let's say, IVF specialist, but what I can give answer according to my experience after the post-menopausal there is a several possibility for the different kind of treatment, like hysteroscopical surgery, to get like a number of eggs, like one egg, like which we can get a dominant follicle, but still, of course, chance of pregnancy very low. And in this case, of course, mostly we just suggest for egg donation.
Thank you for your answer, and I just can add and remind one more time that you can have as Birol said, you can have consultation with a fertility doctor, and it's better to do some blood test, ultrasound check, and so forth to know your medical history, and we need to know more information, and then maybe we can find a solution, or as I said, it was said, try egg donation. So if there are no questions, I just need to check our chat. It seems that we answered all the questions. If you have questions that we didn't answer or you want to know more, you can check our YouTube channel. We have 2 YouTube channels. You can check IVMED Fertility Centre, and there are videos of our previous webinars, and there will be video downloaded this webinar to the YouTube channel. You can check, or if you have any questions, you can send us the pleasure to the email, and we will answer them. So thank you to Olga, to Birol for participating in our webinar and answering all the questions. And I'd like to invite our guest to our next webinar. We will also do the Q&A session and like online meeting with our specialist, and you can ask all the questions that you have. So have a nice weekend, and see you next week.